I'd first like to introduce Lynn Blewett. She is Director of the State Health Access Data Assistance Center. Dr. Blewett is an associate professor in the University of Minnesota School of Public Health in the Division of Health Policy and Management.
And I want to thank the United Way and the opportunity to participate in this panel, and it's always so encouraging that so many people are interested, and there's such a good, rich discussion that I hope it's fruitful in the next legislative session. It's probably the worst time in our nation's history to be doing health reform. I mean, there just isn't revenue, there are no resources, and my favorite slide in my health systems class is the federal deficit slide, which is now approaching $2 trillion, which is about as much as we spend on healthcare in this country. So the underlying crux of the problems and the issues at this point in time are financing and where the revenue is going to come from. And as our commissioner so eloquently said, you either raise revenue or you cut services or eligibility. And so that's where we're at in the struggle for health reform. I'm going to just highlight a couple things of Massachusetts. The Massachusetts health reform was really the state with Republican governor, a Democratic legislature, which the model of federal reform is based on. And they had a couple key components which you can see reiterated in the national reform debate. That is an individual mandate. Everybody is required to have coverage in the whole state. The second is there's an insurance exchange to organize the insurance market, requiring insurers to take all people who come without regard to pre-existing conditions, and all those pre-existing conditions will be covered. The insurance exchange is also the vehicle for a subsidy to help people bring down the cost of the premium. And so the subsidy is for those who have too high of income to qualify for Medicaid or public program, but too low income to purchase a private insurance premium. And the other thing that they did was developed enrollment and retention strategies for Medicaid and their S-CHIP programs. So many of you may know that Massachusetts had an uncompensated care pool. So instead of having a formal GAMC type of program, they had a pool that the hospitals all financed through an assessment on the hospital revenue. And when a hospital had an uncompensated care patient, they basically billed the pool and got some payment from the pool. And when the Massachusetts health reform happened, they took all those people that were in the uncompensated care pool and auto-enrolled them into Mass Health. And so there was no dip in coverage and no change in their care, and they were automatically enrolled. Much of what the states are doing now, because of a lack of resources to really expand eligibility, is trying to get people who are eligible for programs enrolled in existing Medicaid and S-CHIP programs. 70% of uninsured children are currently eligible for public programs. So the idea is, how do we get those kids enrolled and keep them enrolled in programs that currently exist and are funded? The key to the Massachusetts Health Plan, of course, is financing, and what many people forget is they had about $1 billion of federal funds on the table that they were going to lose. And so there was a negotiation with the federal government in terms of use of those funds to fund the Massachusetts Health Plan. So that really was a stimulus and allowed them to do this expansion because they had that federal financial support that we currently don't have at this time, and no other state really has. As the current national reform, they have not addressed the health system issues, the costs of care, the structure of financing, and so similar to the national health reform, we're really expanding eligibility and increasing access into a fairly inefficient and increasingly costly system. So Massachusetts is at a point right now where they're trying to do that. There's a lot of issues around affordability of the premium subsidy and how many people can still afford health insurance premiums even when they have a subsidy through the program. Most states do not cover low-income uninsured adults, and they are not currently eligible for Medicaid unless they are severely disabled. I learned a couple weeks ago that substance abuse does not qualify as a disability, and so most people on GAMC have some type of substance abuse or mental health issue, and if it's substance abuse, they would not qualify. And it's a long history of why they're the one category of individuals who are not currently eligible for public programs. Now, several states, including Wisconsin, have used a waiver authority under the Medicaid program, which the state applies to the federal government, said we'd like to use some of our Medicaid dollars and expand that to low-income adults. So BadgerCare was one of those initiatives. They expanded more rapidly than they had thought because in addition to GAMC, many working adults are losing coverage due to the economy, due to the increasing costs of health insurance. Employers are dropping coverage, and they currently had to, I think it was just 6 months, they had to put a cap on the enrollment because they could not afford to include additional people in that population. In terms of national reform, the basic model for access expansion is building off the Medicaid program, and it includes coverage, Medicaid coverage for all individuals in the country, including low-income adults without children. And this is exactly the GAMC population would be eligible. And there are different eligibility levels, 100% of poverty or 133% of the federal poverty level. But as you've heard, those initiatives do not take effect till 2012 or 2013. So Minnesota really needs a bridge program until we get to that stage where the health reform, and I do believe it will pass, and I do believe that Medicaid part of the federal reform will pass. The issue, again, of course, is financing, and at one point on the House side, it was 100%, any expansion was going to be fully funded by the federal government for a period of time. Well, that has gone away, and there'll likely be some federal match. It'll be likely more than we get right now, but the question is, I think it'll all be in the budget negotiations at the end of the game in the conference committee of how much match the federal government can provide. If they can provide additional match to the state contribution to the program, that'll be a great benefit to the states. In addition to the federal Medicaid expansion, so that's up to 133%, and then you have additional subsidy for low-income working adults up to potentially 400% of the federal poverty level. And that would be through a premium subsidy that would be administered through the insurance exchange. So the basic tenet of health reform is the access expansion for very low-income populations and the organization of the insurance exchange, very similar to what Massachusetts has done, and will be in a few years after implementation addressing the same issues of affordability, the cost of coverage, and financing. Another point in terms of the financing of moving the GAMC population to the Minnesota Care program. So Minnesota Care is financed by a 2% tax on healthcare providers. And so that fund currently has a surplus. It's not a huge surplus, but that fund funds Minnesota Care, which is designed as similar to a commercial insurance product where you pay a premium, you pay copays and deductibles, you have a network of providers, and so it's very similar to an employer-based insurance product. The GAMC population is not a working employed population, and a premium is not likely what they're going to be paying. Now, the county might be able to pay that premium, but it's just a totally different population. And so it's not targeting the right population in terms of moving them to Minnesota Care. The other issue is that should the healthcare providers in the state pay for the care of the poor? Or is that a responsibility of the entire population, which currently pays through the general fund, a general income tax? And I think that's a question that we ought to really talk about, whether the healthcare provider should be paying for the poor of this state. And in addition, the cost of the GAMC population is about 3 times as much as the Minnesota Care population. So the concern is once you enroll them in Minnesota Care, they could basically squeeze out all the other Minnesota Care enrollees and basically leave Minnesota Care to be the new GAMC program without any room for or financing for the Minnesota Care population. I do think we're going to get a bill. If Larry's here, he can affirm that or not. And we thought it was going to be mid-December, but holidays are coming up. Now we're talking mid-January. And the focus, I think, again, will be on those access expansions. And I think that's a good start. And I look forward to more discussion. Thank you.